a lot of people have requested this topic. I'm really excited to turn this over. Thank you, Dr. Stacy, for taking the time today to talk about common oral lesions, pathology, what to look for, and how to treat. I'm going to go ahead and turn things over and we can get started.
So we're going to talk about oral pathology, diagnosis, and treatment. And it's April 26th, and April is Oral Cancer Awareness Month, so it's kind of just in time. We're going to discuss common lesions of the oral cavity found in routine examinations, review the systemic disease manifestations that may present as oral lesions or impact dental treatment, identify when to biopsy a lesion, understand treatment options available and which medications to administer, and to determine how to properly manage patients presenting various oral pathologic lesions. First, we're going to start with oral candidiasis, which is comes from Candida albicans, which is an opportunistic yeast that we have commonly in our human gut and human flora. This is an opportunist infection that we see. Sorry, I'm just bouncing back between two screens. That's why I'm just doing this. That we see with people that suffer from stuff like diabetes, anemia. There we go. Systemic antibiotics, from wearing dentures, from xerostomia, dry mouth, and also loss of vertical dimension causes an angular colitis, which is the buildup of the fungus in the corners of the mouth. We see this on the lips here, the inside the buccal mucosa, the soft tissue. We can see it on the tongue. We see it again on the tongue.
Dr. Stacy, I'm not seeing any new slides.
Oh. Okay. Can you see this one?
Yes.
Okay, so this is from a denture. See the denture?
Yes.
Okay, yeah, sorry about that. So can also get it from denture wear. So how do we treat these? Can you see this slide more on the cheeks?
So we can't see it. So maybe if you exit the screen, we'll just do the smaller version for now.
This way?
Yes.
Okay, sorry about this, guys. So we can see it on the cheek here. It just looks like a white kind of patch. Some more on the tongue. And then now here it is on the corners of the mouth, the angular colitis. This is from loss of vertical dimension. Patient doesn't have their teeth. They can't open their mouth wide enough. Another example here is a patient that has it. She gets this from taking her medicine. A certain medicine that she takes causes her to have it.
Dr. Stacy,
So how do we know this?
I'm so sorry to interrupt you. Do you mind closing the format button on the right corner? It'll make your slide look a little bit bigger. Just unclick format. Perfect.
That did it?
Just click it one more time.
I'm on a Mac. I don't know if I have the same.
Okay. That's okay. We'll continue.
Sorry.
That's okay.
How to diagnose this? We can see that these plaques are removable. They can wipe off with your finger. We treat this by using an antifungal treatment. We have stuff, such things as nystatin, which is like a cream. You can use a Miselex-Troche, which is a lozenge that the patient can suck on. You can also give a systemic diflucan pill. And then you also want to treat the denture. So you want to use something like this Mycolog 2 cream. Next, this is something that we see kind of often too, herpes labialis. That's from the herpes simplex virus on the lips, outside the mouth. Patients come in with these cold sores or sun blisters. It's a reactivation of the herpes simplex virus that lays dormant. Ways that this virus can be reactivated are from certain stimuli, such as a fever, high stress event, hormonal changes, fatigue, upper respiratory infection, suppressed immune system, extreme temperature, and then also recent dental work. Sometimes the cotton roll or the suction is in that area and it causes the virus to reemerge. About 20 to 45% of the adult population have herpes. 1/3 of them experience recurrent outbreaks. They feel prodromal symptoms, such as like a tingling on their lips. And that usually then after that symptom, Usually you'll get this fluid-filled vesicle. That's the most contagious part, but it can also be contagious at all stages. So you want to decide if you want to treat this patient or send them home and get them back when it kind of cures up. Here's some more examples. So now it's kind of a time thing. When patients start to feel that prodromal syndrome, the tingling, they want to start getting treatment right away, some kind of medicine. So they can go over the counter and buy an Abreva cream. You can prescribe them a Zovirax ointment cream, or a lot of times people are asking for Valtrex, which is a pill commonly given for herpes, and you take 2 grams as soon as you start to feel the symptoms, and then 12 hours later you take another 2 grams, and usually that completely eradicates it. You don't get any outbreak. Another modality treatment is laser treatment. In the mouth now, we have recurrent intraoral herpes. That's going to be the cold sores in your mouth, the ulcer lesions. They're on the attached gingiva. They kind of make clusters sometimes. You know that it's that because it's on the attached gingiva there. Commonly, also that looks like the herpes virus is an aphthous ulcer, or more commonly known as a canker sore. That occurs on the soft tissue, the buccal mucosa, commonly called a canker sore. Where it's from, we don't know. We don't know if it's a virus. We don't know if it's a bacteria. But we do know some of the symptoms that help to bring it on. So people can have allergies to certain things. I find that sodium lauryl sulfate, which is the chemical in toothpaste, if it's higher up on the ingredient list, a lot of people are prone to more canker sores. You get a canker sore from stress, trauma, nutritional deficiency, hormonal changes, hematologic abnormalities, and sometimes a genetic predisposition. So just a couple of examples. There's a major one right there on the lower lip. It's got to be really painful. And on the tongue, you can see like over there, those little clusters. They're called herpetiform, although it's not anything to do with the herpes virus. They just kind of cluster like that. You can have like a bunch, and then they can form and fuse into like a major one. Another one here right in the vestibule. And this is a tough case here, aphthous stomatitis, where they just got a whole bunch at the same time.
Dr. Stacy, do you mind if I switch out and I'll share my PDF?
Okay.
And then you can just let me know as you're talking, I can switch over to the next slide.
So I close this?
Yes, please. And then I'm going to share my screen. Okay, can you see that?
I can, yeah. Can everybody
Okay,
else?
perfect. Perfect. Yep. So you just let me know, or as you're talking, I'll advance as you're going.
Yes, so these are aphthous stomatitis. Okay, so how do we treat the next one? The diagnosis is just going to be clinical. You're just going to be able to observe it in the mouth. You don't need to send for a biopsy. You kind of tell that it's the ulcer. And usually they last between 7 to 14 days. And that's the rule, kind of the rule book. If something lasts longer than 14 days, then you want a biopsy. But in this case, we can tell that it's the aphthous ulcer. So what do? There's really no treatment for it. Like they said, we don't know what it comes from, if it's from a virus or a bacteria. So we can have the patient use an over-the-counter anesthetic, some creams they can buy. They can use a rinse. They can use a topical steroid, corticosteroid, something like the furosemide gel. Apthosol, you can do cauterization. And if they have a really serious case and it's really bothering, you can give them some kind of systemic steroid, like a prednisone taper. And there are also some indications for using a laser. But you also want to rule out a systemic disorder. You want to make sure that nothing else is going on that we don't see, that we don't know. So you want to be able to send them to their doctor for a check. The next slide is just pointing out some of the over-the-counter modalities you can use. A lot of patients like that Paroxyl. It's an antiseptic rinse. Also, I found, so that one jumped. Sorry about that. Also, these are some of the next slide. Yeah, thank you.
No
Yeah, the other issues you want to rule out, why patients getting so many ulcers, so many aphthous ulcers, canker sores. I think the next slide I have is magic mouthwash. I don't know if that one made it here, but that was for, no, we skipped it. Okay, there's another mouthwash called magic mouthwash that patients have been asking me for requesting because it has 1 part lidocaine, one part diphenhydramine and one part Maalox, and they swish with that, and it gives them great relief from canker sores. This next slide I was going to talk about is another little ulcerative lesions in the mouth, and we already did herpes and we did aphthous ulcer. So we're going to ask, what's this one in the back of the throat there? Next slide, we're going to see that it's herpangina, which is kind of common too, especially in the summer, especially with children, from the Coxsackie virus. This again is just clinical diagnosis. You can check the kid has a fever, or the patient has a fever, and there's nothing really we can do about it. It's just self-limiting and just some rest and some fluids. Next is an important one too. We're going to talk about lichen planus. Lichen planus is white patches in the mouth that kind of makes a lace-like pattern, or Wickham striae. Next. Oh, there's my magic mouthwash. Sorry for the order, guys. Next one. Yeah, okay. Lichen planus is a chronic mucocutaneous condition thought to be the result of cell-mediated immune response. Affects about 2% of the adult population. Presents intraorally as white striae and patches. Next, there may be an association with hepatitis C. Patients that have that, sometimes treatment doesn't really help. There's a slight increased risk for squamous cell carcinoma. So this needs to be reported. You need to follow up with your patients. You need to document it. And you need to make sure they're aware. This is an example on the cheek. More examples on cheeks. The back of the throat, the palate there. The attached gingiva and the gums. Next, yeah. Can be on the tongue. A couple of examples on the tongue here. Yeah, more in the cheek. Okay, so then this is what helps us aid in our diagnosis here. There'll be multifocal bilateral lesions. They'll kind of wax and wane. It comes and goes. Patients sometimes notice it, sometimes they don't have it. The Wickham striae, I was saying, that lace-like pattern. Also, sometimes there are lesions on the skin that can also help you make your clinical diagnosis. You also want to get a history. The patient has family that have it, or they have a medical history of it. The lesions on the skin are going to look kind of purple, and they're a little bit itchy. They're flat bumps. Can take several weeks to develop. And in that case, I would probably send to a dermatologist, but the medicine you want to give would be a topical corticosteroid pills, or some kind of light therapy, which I know dermatologists are completely against, but it helps. That was the next slide. And then there's more examples on the gingiva and the cheek again, just to see that lace-like pattern. Yeah, so you want to biopsy this. If it's there longer than 2 weeks, that's the rule book. We want to do a biopsy. So we want to send out for a biopsy to establish the diagnosis. What you'll see on the histology when you get it back, if you're interested and you want to read it, is this sawtooth, like that saw-like pattern there, sawtooth appearance of the lymphocytic infiltrate. That's what you kind of see going into the epidermis there. Some treatments that you can use, again, like I was saying, it could be topical. Oh, these are just mimickers. Sorry about that. Next one. Next one. Yes, biopsy, and then some steroids. You can give dethamethasone elixir. That's a rinse that people swish with, and that really helps bring down any lesions and any pain the patient might have. Again, the fluocinamide gel you can prescribe, clobetasol ointment, and then if it's really bad, you can also give them the prednisone taper again. Next, we're going to look at geographic tongue. That's another lesion on the tongue, but it's completely benign. People just have this different pattern to their tongue, and it kind of moves around, hence the geographic name. Some of them are more specified looking, and then some of them are just kind of vague, kind of blunted looking. Some of them make pretty little patterns, and yeah, just a few more examples. And you can even see them in kids, get it at a younger age. No treatment. There's also been another link that could also have eczema, which is a skin lesion. So that's another aid in helping you make, that one's the pretty one, helping you make your clinical diagnosis. Yeah. Just a couple more. Possible eczema connection. Next, we're going to talk about leukoplakia. Leukoplakia is described as a white patch or plaque that cannot be characterized clinically or pathologically as any other disease specified by the World Health Organization. It's a clinical term. It doesn't really imply a specific diagnosis, but it could be the precursor to keratosis, benign epithelial hyperplasia, keratosis, dysplasia, and squamous cell carcinoma. So you have some examples here of this white patch. Notice it's different than the lichen planus. It doesn't have that lace-like pattern, but it's a white patch, which is just the name for, could be a bunch of things. Here's another lesion on the tongue. It is considered premalignant, 4 to 15% chance dysplasia, and common areas you see it on the tongue, the floor of the mouth. Those are the high-risk areas. Next slide. And so again, we go back to our rule book. Anything that's there longer than 2 weeks should be removed and biopsied. Nothing should be in the mouth that long. There are some other leukoplakias that aren't terribly serious. Next slide. Again, we have lichen planus that we saw. The next slide over there is on the side of the tongue. Sorry, that one. Next picture. Thanks, Nicole. Is like a contact stomatitis. So just from the patient putting cinnamon on their tongue. The bottom there is like cheek biting. So those are white patches, but we need to take a history of what the patient did to rule out if we need to biopsy and if it could be something serious. Other lesions that are not white are pigmented lesions. You see these on the palate, the lip, and those should also be biopsied. I would prefer to send to a dermatologist or a different type of physician, somebody that deals with the skin and those kind of lesions, and let that be under their care. But it's also important to see that some patients do have a different color and pigmenting of their gums generalized, and that's not something that we need to worry about. Some other examples of leukoplakias or white patches are leukodemia, which is just an irritation, chronic cheek biting, another irritation, toothbrush abrasion, hyperkeratosis, and then another hyperkeratosis abrasion from sharp tooth structure. So that's why you want to take a history. Side of the mouth, frictional from grinding or for biting your tongue. You want to take a history. Next is smokeless tobacco. Patients still put that stuff in their mouth and, get the tobacco nicotine effects from it. So that's something, again, you want to take a history, and you probably do want to biopsy this if this patient is using any type of nicotine products, and monitor. This is another placement, a keratosis of somebody placing cocaine on their gums, and then aspirin. Patients have like a toothache and they crunch up an aspirin and they put it on the gums in the area, and they maybe get some relief from that, but it really just burns and gives a kind of chemical burn to the gums. So you want to take a history. Let's see. There's also some soft tissue masses we need to be aware of. Can be from salivary glands, inflammation, like a mucocele. You have a fibroma, lipoma, papilloma, pyogenic granuloma, or a denture polyp. So this next slide shows on the tongue there a fibroma, the palate a papilloma, and then in the lower lip a mucocele. So you can biopsy these or completely remove them. It has to do with the patient if it bothers them. I would think that one on my tongue would bother me, so I probably want that removed, and then send for biopsy, and then they'll do the histology on it just to rule out anything. The next couple of lesions are kind of important nowadays. Syphilis is making a comeback. We haven't seen this in a little while, but syphilis is on the rise. It's soaring in the US. This is the typical chancre lesion. You see it in the mouth, you see it on the body, but we're first to see it in the mouth. Cases have risen by 80% since 2018. I think that's huge. This is the highest rate of new infections since the 1950s. You can see the lesions on the side of the tongue. That's a typical chancre lesion. And so now, why is this back in our world? Why are people getting this again? So there's a higher increase of substance abuse, more people taking to alcohol and stuff. Also, in the 80s and 90s, we were overwhelmed with HIV and people were being very careful. But now that we have better prevention and better treatment, people are being a little bit riskier. And so syphilis has been able to spread. Also, a lot of patients are asymptomatic. Like 50% of people with syphilis don't even know they have it. It's a great imitator. That's what it's been called. Um, it's been acting like other diseases, so people don't realize that they have it. These are some lesions on the skin. This is on the hands. It looks like it could just be an allergic reaction or contact dermatitis, maybe eczema, maybe a rash, but that's similar syphilis. That's the great imitator. On the feet, you can see more of a chancre lesion and on the hand. And so that can help you with your diagnosis. And even children, if it gets transferred onto children, they can get these Hutchinson, next slide, the Hutchinson incisors. So that's another way to help make a diagnosis. Next is kind of a new buzzword, kind of important. We've been hearing a lot about this on the news. I don't know if just because I'm a female, but I think everybody's kind of more tuned into menopause. And you see this diagnosis with women that suddenly they have reduced saliva production. They're getting more cavities. They have more plaque buildup. Maybe they have more gum recession, more sensitivity, even like a burning tongue. And loss of bone density, so they're getting loose teeth, they're losing their teeth, periodontitis. This is something that we can see in the mouth and help our patients to find a diagnosis of what's going on in their body and why all of a sudden do they have what we would say like poor oral hygiene can really just be limited to being menopause. So there's a couple of treatments that we can give them to help them soothe them and help to restore their oral health. There's some dry mouth rinses they can take, like a biotine. There's some lozenges, there's gels, there's toothpaste, there's gums. Anything with xylitol in it is really helpful. I would also refer them to their doctor. Maybe they want to put them on some kind of hormone replacement like estrogen and estradiol and progesterone will decrease dryness all over the body, so increase moisture in the mouth. So knowing all of these things now, we want to use our tools here. We want to know how to do our oral pathology exam. We want to examine these parts of the mouth in particular. We want to look at the tongue, the dorsal and lateral borders, the floor of the mouth, the buccal mucosa, the lips and cheeks, the gums, the gingiva, the palate, and also the back of the tongue. This is an example of how to do your exam. So you want to grab a piece of gauze and you want to pull the tongue to the side, both sides you want to check. You want to pull the tongue up. You want to look underneath the tongue and the floor of the mouth, which are very common areas for lesions. You also then want to palpate the lips and feel inside the cheeks, go all the way around, kind of in like a circular motion, feeling like everything. And then you also want to use your finger, we call it like the finger tickle, and kind of pull the patient's tongue down and feel towards the back of their throat and kind of basically gag them. But when you explain to them why you need to do it, there's a lot of cases of us finding bumps in the back of the throat, such as HSV. HSV has kind of been on the rise as well. And if we can diagnose that before the patient, then hopefully we've at least saved them and cured them. There are also with HPV on the rise, there's some vaccines for it now, such as Gardasil. And so once you've done your oral exam, you want to know if you should biopsy. And as I said, again, the rule book is 14 days. Anything that lasts in the mouth longer than 14 days, you want to biopsy. You want to send to a pathologist, or if you're comfortable in your own office doing it and you have the bottles and the forms to fill out, you can send it to pathology lab. You want to be sure that there's nothing malignant or pre-malignant. Anything that's growing rapidly is cause for biopsy. Anything that is fixed and anything is in one of those high risk areas that we were talking about. And that will help you confirm your clinical diagnosis. You want to document everything, and you want to follow up with the patient and always be aware and explain to them everything and any medications they may need. And thank you. This slide was supposed to be there. Sorry. Thank you. Thank you, everybody, for listening. I hope this was informative.
I'm sorry, I was muted and you couldn't hear me. Thank you so much for this. So when it comes to syphilis, you're saying that it's on a rise. Are you seeing more lesions on the tongue? Like, are you going to see it first in the mouth, or will you see skin lesions outside on the dermis?
It could be both, but skin lesions, yeah, that's the primary infection, and then the secondary. So yeah, it could be both places.
Okay, great. Thank you. We have a lot of questions coming in. So do you have, so I'm just going to start reading them. So there's tongue with a white coating and causes bad breath. Do you have any ideas what the cause and treatment could be?
The white coating causes
So
bad
they
breath.
have, it sounds, sorry, if somebody's coming in with white coating on their tongue and and they have bad breath.
If it's removable and you could wipe it, it could be like I
Mhm.
was saying, the Candida albicans. It could be the fungus. That could definitely cause bad breath. If it's fixed, it could always just be bacteria on the mouth. And if there's a patch, I would biopsy it. Like I said, if it lasts more than 2 weeks. Bad breath is also caused by some kind of acid reflux too. So they may be taking something and then that's kind of burning their tongue, and that's the white. Could also again be menopause, like I was saying, the lack of saliva.
Yeah, it's really taking a history, like you were saying, and that perfect. Okay, so what would you also describe antiviral meds for intraoral herpes as the patients don't usually feel it until it's in the visceral phase, no pre-tingling?
Yeah, you can still prescribe the Valtrex and see if it helps. If it's already emerged, it may only reduce some of the time or it may not do anything, but it's definitely worth it to take it.
Okay, and then how about when somebody presents with an aphthous ulcer, would the physician check, what are they checking for with a blood test? Do you know?
Yeah, it would be like a CBC, a complete blood panel, and they would check for any type of anemia, any type of, like lack of red blood cells, stuff like that. Maybe a thalassemia, any type of serious, more kind of anemia. Maybe celiac disease where they're not getting the right nutrition. So I think it was the IG, one of the IgG immunoglobulins, similar things like that.
Excellent. And then can you go over the components of the magic mouthwash again?
Oh, Magic Mouthwash is 3 parts. 1 part lidocaine, 1 part diphenhydramine, which is Benadryl, and 1 part Maalox. You can find a pharmacy that will compound it. Like CVS will say they have it, but it's just lidocaine. If you can find a pharmacy that will compound it and put it in those threes, patients like swear by it. They're cured. I've had patients find me like online just because they want that mouthwash. It's
Great. It's a really good mouthwash. I've given it to patients before.
yeah.
So if a patient has lichen planus, but the lesions are asymptomatic, can we just keep the patient under observation?
Yes, you definitely should. You should document it, maybe take photos. If they don't want to take any rinse, they don't want the dexamethasone or they don't need any fluocinolone gel, anything like that, you don't have to give them anything. But you definitely need to monitor it in case anything changes.
Yeah, and document.
Document.
Yeah. What will be a preliminary diagnosis or impression of mid-palatinal mass, sorry, in the side with a possible mucocele on the tongue? What will be?
Palatine. So it's on the palate.
It is on the palate. It's a palatal mass. It's a possible mucocele. They're wondering if there's a different diagnosis that could be. I'm
Uh,
sorry. Let me ask you a different question. What is the treatment for PVL?
PBL.
Sorry, we're going to need some more specifics on these questions. I don't know what PVL is. Let me, can you talk a little bit more about Hashimoto's disease or autoimmune disease and how it relates to the dentist and oral pathology?
Yeah, any thyroid. Thyroid is kind of the master house organ, so that provides and, tells the body kind of what to do. So that can also cause any of these lesions. It's a immunocompromised situation. So any of these other lesions or diseases can present themselves in an opportunistic way.
Awesome. And then do you have any suggestions on how to prevent tonsil stones?
Tonsil stones. I usually tell patients to swish or gargle with peroxide uh, every night, and that helps to prevent them from building up. But then I know some people go with like a Q-tip and pick it out. But I think the best thing to do would be like peroxide, half water, or that peroxyl rinse I was talking about, the
Hmm.
antiseptic. A lot of people using that, just gargling every single night, and it kind of keeps them at bay. But Nicole, how about you? What would you say?
I love the peroxyl. I think it's a great, we would have patients pop them out sometimes. Over the counter, the TheraBreath was really good, or just
Yes.
rinsing with warm salt water.
Yeah.
Yeah, just really just keeping your oral hygiene clean. Tongue scraping is a big one just to help reduce as much bacteria as possible because the bigger the the stacks are, the more bacteria gets stuck in there. So you just want to have really good oral hygiene.
Very, very antiseptic, very good healthy mouth.
Yeah. Is there a difference between like, have you seen with like COVID tongue versus syphilis tongue? Like, is there,
COVID tongue, yeah, that's another thing. That's a history. You have to ask the patient. I mean, I had one patient that wouldn't come in. She kept sending me pictures of her tongue from this far away. And I kept saying, like, I can't see it closer, put a light on it. So she's got a flashlight all the way back here. And after asking her, I said, "You haven't left the house. Did you get a vaccine?" And she said, "Well, yeah, 3 days ago I went and got the COVID vaccine." And I was like, "You have COVID tongue." And so that just resolved on itself. There was nothing we could really do. I did have her go get the peroxide and switch with that to keep her
yeah.
mouth as clean as possible. But yeah, you do see that too. So that's the history. You have to take a good, medical history, what's going on with the patient.
Yeah. It's really sitting down with them and asking them questions and really getting to that information. When it comes to biopsying for lichen planus, do you think a brush biopsy is good enough or is a punch better?
A punch is definitely better. And you want to go to both sides. If the lesion is like, that's really big, but the lesion is like this and it's whiter here and then redder here, you want to get both spots.
Nice. That's great information. Is there is laser biopsy available or is that advisable? Is
I
that a thing?
don't know, laser. No, I think you're better off with a blade or a punch.
Okay. And then PLV was proliferative verrucous leukoplakia. So they were asking, let me go back up, what is suggested treatment for that? For the
I
proliferative verrucous leukoplakia.
Yeah, I guess you would have to find out the
Listen.
histology, see what's causing it, the etiology, and then um, one of the steroids topical intraoral.
So I kind of want to talk a little bit about like HPV lesions. Somebody is asking like what that lesion would look like in the mouth. There's a lot of great research on the vaccine on reducing it's actually helping to prevent HPV in the future. But what do you recommend? Like what are we looking for HPV lesions?
So when you do feel in the palate, the back of the tongue there, you may feel like a bump, something that's not supposed to be there. And then you would ask a history of the patient. Do you have problem swallowing, eating? How is it? Anything raw or bleeding back there? And also you can sometimes see little warts, HPV, like on the attached gingiva. And you can biopsy that too. And then based on your histology, you can make the diagnosis.
Is that like an advanced stage of HPV when you're starting to see it in the mouth, or do you?
I guess, yeah, when it goes to the back of the mouth, yeah, that's pretty advanced. That patient is probably going to need chemotherapy or removal, stuff like that. But the smaller lesions on the gums, maybe not. But you want to make sure which kind it is. The HPV 16, 18, and I think 31, 32 are the most cancerous or pre-malignant. So you want to make sure what marker that patient has and then to monitor them.
Sounds great. And then for menopause, we know that that's a big one. It's a hot topic. A lot of people are talking about estrogen and hormone imbalance. Are you recommending to bring these patients in more often? Are you seeing more bleeding in the mouth? Like, how would you treat somebody who's either perimenopausal or in menopause?
Yeah, absolutely. Bring them in more often for cleanings until you get them under control. So I was saying like the dry mouth stuff, the rinses and the gels and everything like that. So more frequent cleanings. Yeah, maybe put them on a 4-month recall or a 3-month recall if they've already only been on a 6-month. You want to be able to get that at bay and under control because you don't want them to be getting cavities, losing their teeth, bone loss, recession.
Hmm. Yeah, you see a lot more inflammation from being a hygienist. Like that's something that I would recognize. Okay, something's changed. I've been seeing you for the last 3 years, and now we're starting to see more inflammation. There's more bleeding. The pockets are changing just a little bit. Like what's going on? And then you talk with them, and sometimes they don't know, and then other times they're like, oh well, I started going through menopause, and so then we would bring them in like a little bit sooner just to help reduce that biofilm and bacteria levels and really increase their hygiene if they're not doing or try something different like if they're flossing maybe a water pick.
Yeah, or if they're not using an electric toothbrush, now they have to use an electric toothbrush. And then the toothpaste
Absolutely.
gives is dry mouth. We really don't want them using something like with the SLS that may be causing more of an irritation and a bleeding.
Yes, I wish all toothpaste was SLS free. Yes. All right, well, thank you, Dr. Stacy. This was a lot of great information, and thank you all for joining us today. Be sure to join us next week when we have, as always, our business advisory panel, and our guest speaker will be Dr. Stephanie Tilley, and her topic is implant emergence profile, the surgical approach. So let's meet back here next week, same time. Thank you.